everyone. Oh my gosh, I feel so important. I love the announcer. Whoever's that voice is amazing. And I don't know, I was like, is this AI or a human? But thank you so much. I really wish I could be there in person, and I'm sorry that I'm joining virtually. I especially was sorry to miss the icebreaker. It looked like it was a fun, or the gathering time, and so it looks like it was very fun. And I hope I can come in person next year. But I'm delighted and honored to have been selected for the moderator for this session, especially in a year that the annual conference, the Sickle Cell Summit, focused on pain. Like, let's talk about pain, the seen and unseen. And that's quite important to me. I just wanted to show the inspiration behind the painting and behind the session that we have today. So many of you are familiar with this painting. This is the painting by HERTZ NAZAIRE called 10 Redefined. It is my favorite painting of his. And he has so many beautiful, gorgeous ones. But I see it as a call to action. And I think I actually feel like it sees me, like it gets me. And I'm sure many of you living with sickle cell disease feel the same way. I like to say that this child is crying, yes, because of the excruciating pain of sickle cell disease. And we see the red blood cells there that are contributing to that pain. But I also feel that the child is crying for another reason, a reason that is about the societal burden of having a disease that is understood and being invisible to the eyes of the community, not being respected, with the stigmas that are associated with sickle cell disease. And so however you decide to redefine sickle cell for people to get it and to understand, I continue to be impressed and admired by all of you that are out there advocating for what is for better outcomes for sickle cell disease, especially for people to understand about the concept of 10 Redefined. And so I'm excited to kick off this session. I wanted to welcome up our first speaker, Dr. Jodian Lin. And I believe, I don't remember if she was in person or I apologize. Is she able to join in person?
She is in person.
Okay, thank you. So Dr. Lin, I'm gonna stop sharing the screen so that your presentation can begin. Dr. Lin's talk is called How Do You Report Pain? And then we'll have some time for question and answer, and then we'll move on to our other panelists. So Dr. Lin, why don't you take it away?
Testing? Oh, thank you. This is probably the first podium I don't have to tippy toe, so I appreciate it. My name is Dr. Jodian Lin, and I did my PhD on the topic, Nursing Advocacy and Maternal Health for Black Women with Sickle Cell Disease. So today's topic was perfect for me because I had the honor of interviewing a lot of... Can you hear me? I'll start over. You're welcome. So good afternoon, my name is Dr. Jodian Lin, and I did my topic for my PhD program on the topic Nursing Advocacy in Maternal Health for Black Women with Sickle Cell Disease. So this topic of pain for today is perfect for me because I had the honor of interviewing multiple Black women who are giving birth to beautiful babies, but sadly had pleasant and unpleasant experiences within healthcare. So the topic is how do you report pain, how do you express pain, and is there a need to use a different pain scale? I want to start by telling you a story. Imagine walking into a patient's room at 7 a.m. that is shared with 2 other patients. One patient is yours and another is a fellow coworker's. You, as a new graduate nurse, begin to assess your patient and you hear moaning and crying coming from a distance, and you realize it's your coworker's patient, crying in what seems like great pain. Your own patient's mother states, "Oh, she's been like that throughout the night, in pain and hasn't gotten anything." All you can do at this, as the oncoming nurse, is say, "Oh boy." At 9 a.m., you return to your patient's room to administer morning medications, and you hear the distant patient still moaning and crying. You as a nurse feel some sort of way, and after you give your medications, you leave the room and approach a nurse assigned to the patient, sharing a room with your patient, who happens to be training a new nurse. You tell the nurse, the patient is moaning and crying. The nurse tells you, oh, I'm waiting for pharmacy to verify the medication. Even as a new graduate nurse, you understand that pharmacy can verify medication within seconds if you give them a call. This knowledge makes me uneasy because you know that aspirin can be verified easily, and so can a narcotic. At 11, before going on your breakfast break, you check on your patients. And as you're entering the urinal, you pass by this patient who's still crying. You ask the patient if she has received pain medication, and she said no. I haven't gotten anything all night and morning. You check her chart, and you see that a medication was ordered from yesterday for Dilaudid as needed every 2 hours, but no dose has been given. You check her vitals in the chart and labs, and notice lab values showing the patient has sickled blood cells. You don't do all of this because you doubt her. You do this so when you approach a nurse, you know you have all the information from the chart to support you. You let the patient know you'll tell her nurse she's in pain and would like pain medication. As you exit the patient's room, you let the nurse know the patient is in pain and would like pain medication. The nurse tells you she'll give pain meds. You go to breakfast feeling like you did your part in notifying the nurse that her patient is in pain. 2:30 p.m. comes around, and you're caring for your patient, and you hear the other patient now vomiting and crying inconsolably. Your patient's mother asks you, will she ever get pain medication? It's been hours now. Is this how you guys operate here? At this point, the statement makes it seem like you as a nurse functions in the same way as other nurse, and that's unacceptable. You approach the patient's nurse and ask her, can you medicate her? She tells you, oh no. The doctor ordered a CT scan, and once it's done and clear, she'll discharge her home. You ask her, in the meantime, can she get pain medication? Because she's been crying since 7 a.m. and your patient's mother is voicing concerns. She tells you no. She would rather wait and discharge her after the CT. Now you stand your ground and tell her, if there are no discharge orders, you will medicate the patient because there are orders for medication that were placed since 7 p.m. yesterday, and the patient has not yet received anything all day. Her vitals are stable, she's alert and oriented, and labs show she's in sickle cell crisis. The nurse states that she doesn't want to be part of the problem, and you ask her what problem. She states, nurses who feeds into the drug-seeking behavior, perpetuating the cycle, and helps the pain epidemic continue. This statement catches you off guard, and you feel uneasy, but you tell the nurse how misinformed she was and how her primary job was to provide legal and appropriate care to her patients. You finally tell her you're going to medicate the patient. She was not pleased. In this scenario, which nurse are you? What would you do? Would you be aware enough to identify your biases towards a patient you have never met? Would you be the brave new grad nurse to speak out to another nurse about a practice you do not condone? This scenario shows a refusal by a nurse to medicate a patient in sickle cell crisis, despite being told the patient reports pain and being in severe pain, having a doctor's order for pain medication, the patient had stable vital signs, and they were supporting labs showing the patient was in sickle cell crisis. This scenario is my first encounter with a patient in sickle cell crisis and having to challenge a nurse who clearly allowed her biases and preconceived notions to impact the care the patient received. My conversation with you today will focus on the topic, is there a need to use a different pain scale for patients with sickle cell disease? First, let's talk about the current pain reporting methods currently being used. You have the numeric rating scale, 0 being no pain, 10 being greatest pain ever. Then you have the FACES pain scale, known as a Wand-Baker pain scale. And then you have the visual analog scale, and then the FLAC scale. Those are a lot of scales. And if we have that many scales already in use, and we still have a problem with administering pain medication, we don't need more. The problem isn't the pain scales. And so I will take on the notion that the problem lies with the people using the scale, and in challenging nurses and healthcare professionals to dig deep and to be more aware of our preconceived notions and biases and how that impacts the care we give to our patients. So the limitations that we have for some scales, they're designed primarily for acute short-term pain. And when we have sickle cell patients, we know that there's chronic pain in combination with acute pain. And if we don't have the proper knowledge for that, then we don't know how to treat our patients properly. There's also a focus on intensity only, not the quality of pain, not the duration of pain, not the unpredictability of pain, and also not the emotional impact it has on patients. Now let's talk about why this matters in sickle cell and the challenges with using standard pain scales in sickle cell. We know that sickle cell disease is unpredictable. The pain that comes with it is unpredictable, and it fluctuates. It is also chronic and acute, so a pain scale that would take into account someone's baseline, which is not 0. Patients who have sickle cell disease living in chronic pain will never report their pain to be a 0. They'll have a new baseline, whether it's 4 or 5. Then we have to take into account when they're coming into the hospital for acute pain crisis, sickle cell crisis. What is their crisis pain? So we can have a baseline pain maybe in conjunction with an acute pain scale for crisis. Then you can have a better reference to how to administer pain medication. But using a generic pain scale of 0 being no pain and 10 being greatest isn't appropriate for patients with sickle cell disease. Another thing that patients report that staff makes them feel that they're questioning their pain levels. So you have a patient coming in who's in excruciating pain, and they have to prove to you as a medical professional that they're in pain. They shouldn't have to prove to anyone. Once they say they're in 10 out of 10 pain or whatever number it is, that's the pain they're in. But by having to prove to you, that's a problem. They're already there for something they don't want to be there for, and they shouldn't feel like they're there to prove to you that they're in pain in order to get pain medication. By not believing patients who are in pain, we tend to undertreat pain. If we don't believe someone's in pain, we delay care, we don't treat pain, and pain is directly related with tissue damage. If we're not treating our patients who are in pain, we're contributing to tissue damage. And patients who have sickle cell, we already know they have a decreased oxygen supply to the body. So if we're not treating the pain, they already don't have oxygen being circulated, we are compounding the problem, and we're not making it any better for them. We're increasing length of stay, and we're making their lives more miserable when we only see them for 3 days as healthcare professionals. And they're living with this for their whole life. They're the commander-in-chief of their life. We are there to support them. We're not the ones in charge. We have to believe what they say and take their word for it and do our jobs as healthcare professionals. The evidence from research shows that there's inconsistent correlation between pain scores and observed distress. So if a nurse or healthcare professional doesn't see someone in pain, they don't believe someone's in pain. But again, patients who have sickle cell are living with this chronically. So we can't tell someone what their pain should look like. We can't tell someone how they should cope with their pain. If someone is sleeping, maybe they have pain, the least amount of pain while they're sleeping. If someone expresses it another way or shows it to you another way, that's just how they express it. But it's not for us to say that someone doesn't look like they're in pain, so we don't medicate them. Other evidence shows that high rates of provider biases and stigma reported in sickle cell pain are prevalent. And with that, we have to, as providers, be aware of that so that we are catching it before it happens so that we can treat our patients appropriately and give them the care that they need so that they can go home to their families, because they don't want to be there. They're there because they have to be. They go through so many measures to treat their pain at home through so many modalities that the hospital is the last place they want to be. They don't want to be there. NIH and CDC recommend patient-centered, trust-based approaches to sickle cell disease pain assessment. But how do we get trust-based approaches? That has to come from the healthcare providers taking the time and opportunity to better educate themselves. But will healthcare providers do that on their own? Very unlikely. If we're being honest with ourselves, the only way we'll get education is if it's through the institutions. And so that is why part of my dissertation and intervention moving forward will be going out into the hospitals to try to better educate nurses, eventually doctors, but nurses first, so that we can have better impact in care for patients with sickle cell disease. Thank you. Some of the impact of inadequate pain assessment is, we already spoke about the delayed treatment, but something that I noticed so early on is when nurses get a report and they just hear sickle cell crisis or pain, all they think about is pain medication. But there's so many chances and opportunities to not miss assessment if you're not judging someone. Because if you hear an assessment or an SBAR for a report, will you catch that someone is having signs and symptoms of acute chest syndrome? Will you catch the signs and symptoms of someone having VOC? Will you catch the signs and symptoms of someone having necrotic tissue damage? If you're not judging someone, if you're not allowing your biases to intervene and take place and interrupt the report you're given. So that is something that I truly want to make sure we can, small pieces by small pieces, do within the hospital so that we can educate our nurses to not just look for pain and report, but to see beyond the pain, to see beyond the diagnosis of the person, and to see the person first. Also, with the with the arguments for different sickle cell specific pain scale, I think that one, if we're going to use multi-dimensional indicators, that means you'd have to go beyond using just the number scale. You have to talk about intensity of pain, quality of pain, location of pain, triggers, and emotional impact. Now we're putting the burden on the patient. Now they have to answer more questions. Now they are already, one, you speak to one doctor coming into the hospital. Then when you get admitted, you're speaking to another doctor. Then you're speaking to a nurse. Then you're speaking to a resident. Then you're speaking to an intern. And you're telling them the same story over and over and over and over again. That is exhausting. So a small caveat, I took my son in to get a monitoring for EEG monitoring. And I saw 5 doctors and had to tell the story 5 times. And he was not there for pain. But had he been, I'd have been mad. And it dawned on me, if I'm frustrated for my son who's just getting monitoring for a brain condition, imagine patients who are in sickle cell disease crisis, who are in 10 out of 10, or whatever number they want to say, excruciating pain, and they have to tell the story over and over and over again. And we expect them not to have attitude. We expect them to come in, when we come in, to have a great demeanor, calm, cool, and collected, happy to see you. Why would they be happy to see you when they've seen 4 doctors saying the same thing over and over and over again? So I believe the onus needs to be taken off of the patient and put onto the healthcare system. That won't be an easy task to do, but I have Ms. Pat by my side, and we'll make some good trouble, and we'll figure it out. But one unit at a time, one hospital at a time. But that is my true belief, that the pain scale is not the issue. It's the providers who are using it, and we have to take the onus off of the patient. We're adding more and more responsibility to patients coming into the hospital who don't want to be there. And there's only so much they can handle, and at the end of the day, we're still not medicating them. We put all that responsibility on them, and we want to start them with Tylenol and ibuprofen. When they're telling you what works for them, they know their body more than we do as healthcare professionals. And when I was bedside, if someone's telling me what works for them, I appreciate you. Let me go and tell the doctor. It's not for me to judge you if your vital signs are stable, if you're alert-oriented, and the order's in. My only job is to give you the medication and to monitor you, nothing else. And then we can be friends, because I want to get to know you. And that's how nursing and healthcare should be, but that is not the culture that currently exists, and that's something I hope to change with the help from those who can guide me, like Ms. Pat and everyone else who has more knowledge than I do, and I'm humbly okay saying that. And so that is what I want to do moving forward. So the recommendations for using a different pain scale, even though I don't believe we need one, it would be, first, we'd have to ask and engage patients who have sickle cell disease. Okay, do you think that patients or individuals who have sickle cell disease want to do another study? They want to do another intervention? They want to do another conversation that may or may not have the outcome that they desire? You can't guarantee them that they're going to get the proper treatment going into the hospital. So if we can't guarantee something, I don't think we should pose it and now engage individuals with sickle cell disease to now do something else. Put the onus back on ourselves as healthcare workers, and what can we do as an institution to better educate our nurses? In nursing school, what can we do to better educate our nursing students? Because it's not taught. In nursing school, sickle cell disease is not taught. It's the same small paragraph as Black History Month, and you move on. And we just have to be honest about it. So if it's not taught in nursing school, how do we get it into nursing schools? If it's not taught in the hospital, how do we now get it into the hospital? So the onus has to be placed on us, nurses like myself, to go into these different institutions and challenge them to do better. And that is what I think needs to happen without using a new pain scale. All right. I do want to hear from individuals, if you do believe that a new pain scale would help, what are your thoughts on why that would help, and if that would be too much of, I don't know, if it's a investment or emotional investment or anything that you think it would it be beneficial to use a new pain scale or not? Oh, don't know if she's hopping up to his bathroom or go to the mic or. Oh, that works for me.
Oh, okay. Oh, I get to be fair. Okay. So in our training and providing bedside report, we found that when we say abstractly that the pain is 1 to 10, we don't make any headway. So we try to explain it in terms of behavior. So with my daily pain, is a 3. And under that, I can control it with my home meds and then, give them a baseline. Then I say, if I'm 10, and I could be a 10, I can't think of anything else. I can't eat, I can't sleep, I can't drink, I can't do anything because the pain is so bad. So by giving them actual verbiage to which they can put themselves in without their imaginations and that, what I'm saying, we seem to be able to get a bit more traction. Okay. So I think we have to be very, very purposeful about our language, and we find it helpful. Knowing what your baseline home pain is, knowing, knowing where you need to be before you can titrate down, really. So if I can get to a 6, right? If I can get to a 6, then I know 4 is just a little bit away. If I could have 2 days or 3 days, right. And this is what are the limitations of that pain? And I think that stops or helps. Now, some people, are going to do what they do, but we found a lot of success that way.
I think what you said makes sense because I think it makes it more personable. And so by describing it that way, I think you're bringing the nurse and healthcare provider into your life. And to me, you already drew me in. So now I see your baseline pain scale number, and then I see your crisis number. And putting that together, now I know what goal we can make together to get you to a place to then go home. I like that.
Hi there. Hi. I like your point that we probably don't need another pain scale. I agree, we don't. I think the pain scale that we use has also been validated in sickle cell patients. I am curious what your experience was when you were bedside, because I'm wrapping up a study right now where I interviewed nurses, patients, and residents and MDs on an inpatient sickle cell unit. And one thing that came up with the nurses, irrespective of the fact that yes, there are nurses who are racist or whatever, right? The things that seem to be driving a lot of conflict between nurses and patients had a lot to do with just nursing resource allocation. To do a pain assessment the way you, I don't know her name. Adrian. The way Miss Adrian just described requires a little bit more time, right? Where I work now, and I don't know what the standard is nationally, but at some places, a nurse carries 5 patients on the floor. In residency, the daytime ratio on the floor was 1-3 and 1-4 at night. But even 1-3 felt like a lot in my study. The nurses felt like when I have 3 patients and one of them has sickle cell, it feels like I'm in the ICU with 2 patients as opposed to the ICU with 1. And and so I wonder how you feel. Do you feel like yourself and colleagues would have had more, time, opportunity to really delve into the care you're providing? Because ultimately, there are a ton of rare diseases, right? Sickle cell is one of them. Hemophilia, you name them. There are a lot of rare diseases that people will not have learned about in nursing school or in medical school. But curiosity, empathy are just baseline requirements. But I wonder about this element of time as a resource.
Right.
Yeah.
So I'm a charge nurse at Loma Linda Medical Center in Riverside. And of course, before that, I was bedside. And I don't think it takes that much time. I think, I can't speak for anyone else, but if I were to say that, it'd be a poor excuse, because I'm able to, when I was bedside and even as a charge, and my nurses who are very proactive, we can talk to patients for 30 minutes. We can, if you want to find the time, you'll make the time. And that's what I believe. And it only takes the morning assessment to make a plan with the patient. That's right. Because I can go in the morning, get to know you a little bit, and we come together and formulate your plan. You tell me what works best for you. So if you're doing it in a way where you're really trying to get to know that patient and you're not thinking of it as a task, or you're thinking of it as something that's going to benefit the patient, you'll find the time.
That is really helpful, because I did the study when I was a resident. I spent most of my day in the workroom. I'd see a patient 13 minutes in the morning and then 13 minutes in the afternoon. And I don't know how nurses spend most of their time. But the insight that I gathered from talking to them was essentially that the biggest driver in delays in medication administration is just like, oh, I'm turning a patient over there and now I'm 10 minutes late. But then also when you are administering medications for pain, it's not the same as when you're administering medication like an antibiotic. You don't need to come back and check for symptoms after you've given ceftriaxone, right? But if you've given Dilaudid, you got to come back in 30 minutes. How's your pain? If it's not adequate, go back and maybe draw more if you had a range, or like ask for an additional dose. And many of them suggest then that it's almost as if they're like Q1.5 as opposed to their usual Q3 in terms of patient checks. And so that is what I wonder if I'm patient.
So the units that have a med-surg unit, medical unit will have 5 patients. Their only bulk of medication is at 9 a.m. for all the patients. So once you take care of giving your 9 a.m. meds, everything else is as needed. They can help turn a patient if they want to, but you do have assistants on the unit who help do that. So if they want to say that's the rationale, I can't speak to that, but they have time. And so what I typically would do with a patient is, can you set your alarm for me, or I'll set my alarm and call me in. I have no problem saying I may forget. But the problem sometimes is we're not humble enough to admit things. Some people aren't humble enough to say I forgot and I need to come back or help me, you know? But I don't mind. I'm humble enough to tell you, please help me. And I'm sorry if I forgot to come back. But I think that has to
I'm gonna hop in front of Ken. Because, you know, I understand what he's saying, but I also know that there are times when there are people on the unit with sickle cell disease where people will go all around them to keep from giving them what they need. Is my mic off?
Yeah.
Okay, where they will go all around them, where they will find reasons for why they're not gonna do what they're not gonna do. You know, and the reality is that the patient has already been on the buzzing for hours. And we know how long pain medicine lasts for. So if I gave you your medicine 4 hours ago,
It's gone.
it's gone.
It's gone.
And you are going to be the first person I visit because I know your medicine is gone. And if I don't visit you,
It's a choice.
you're going to make my job harder. Okay, I can make it easy for you, and you will make it easier for me. And I think we have to respect, and we have to live in the real world, that people with sickle cell disease are disproportionately discriminated against and mistreated in the medical arena.
Yes.
And it is purposeful. I can tell you that when I was a nurse, when I first came in sickle cell, there was a nurse who worked on the unit. Every time she would leave the unit, she would take the keys to the medicine room. And it was because the person with sickle cell disease was there and they needed medicine. And she later told me she developed a chronic disease that was punctuated by pain. And she said, Pat, I never believed anybody could be in that much pain. And I just came to apologize to you because you used to always be on my back about people with sickle cell disease and how cruel you're being to them. And the reality was she made a choice to discriminate against, and she looked like me, okay? Discriminate against people with sickle cell disease. And people will always give you excuses for why they can't do what they want. Go in and medicate that person with sickle cell disease and they won't bother you.
Right.
They won't bother you until it's time for you to medicate them again. I guarantee you that, you know. But the way people with sickle cell disease are treated is a disgrace. And anybody who's in the medical profession that does not see it, they need to walk away.
I agree.
Thank you so much. I don't know if you can all hear me. So Dr. Lin, I wanted to confirm that we're entering your Q&A part. Is that correct?
Yep, that's fine.
You already have like a lot of people. I didn't know if you wanted to say one ending phrase before we get started, but we will take time at both microphones. And Dr. Lin will help me acknowledge that. But I am just already blown away by you. You're an advocate and an ally, and we're very grateful for your time. And so let's take a few more questions, but I wanted to make sure you didn't have a final word before the other questions started.
Oh, no. So the last thing I will say is what I plan to do moving forward is to do an intervention. And my advisor who's watching, hi, Dr. Roberts, she sent me, the first year of my program, sent me this old school video. And I was like, what are you sending me? Like, this is like a PCU kind of thing, a CPU thing and this computer. And it was me watching a video and my eyes are blurry and I couldn't see. And we were pulling up to the hospital and the view changes. And the view changes to now this guy in the passenger seat who is in excruciating pain talking to his girlfriend. And his girlfriend says, go and get checked into the hospital. I'll meet you inside. And it was back in the day where the system didn't have a log of medication. She said, don't forget your medication form. So he put it in his pocket. He's stumbling inside the hospital to get checked in and the systems are down. So the nurse tells him, go and sit down. So he sits down. He doesn't notice that his paper falls out. When the nurse calls him back up, he goes up and he's like, what do you need? He's like, I'm in crisis. He's like, okay, well, where's your form? And he's feeling for it and he realizes he dropped it. And the doctor comes up and he's like, what's going on? He's like, oh, he was here last week. He's just here for pain. He just wants drugs. And the guy is trying to tell him, I'm not here for drugs, but he's in such pain, he can't convey that. And he's looking for his paper. He can't even find his paper. And before he could even look for it, he's kicked out of the emergency room. So if that is the life that patients who have sickle cell disease go through, I can't even imagine it. But if I can be a part of the solution in a little bit, whatever shape or form that looks like, with all of your input, I'm open to that. I'm receptive to that. I'm humble enough and honored to be a part of that change. And I appreciate you for letting me into this community because you guys are amazing people. And I'm so sorry you have to endure what you go through. But we will get more allies on your side, somehow, some way.
Thank you, Dr. Lynn. Yeah, and Dr. Lynn, there was a virtual statement during the commentary about how much a patient has to do when they're in pain, and I just wanted to add it. It says it's best to write that info down, like the information about the person, and give it to the emergency room nurse or doctor, because a person in pain may not be able to say all those things. And so I just wanted to add that in. And so if we can go to the gentleman, I believe in the green with the hat, if he wants to take his question, and then we'll go to the second microphone.
Absolutely. Okay, yeah, I think it's working.
Yes.
First, I do want to thank you so much for being an ally and understanding the difference that nurses can make and the challenges that we do face. Addressing the issue of whether we need a different pain scale or a different way of presenting and explaining our pain. You know, my last hospitalization, second to last hospitalization, I was in a lot of pain. And I expressed to this doctor, you know, that my pain was an 8. And I don't go straight to 10, because even if I'm at 10, you know, my face is pretty much going to look the same. And doctors don't really understand that when you've been dealing with pain your whole life, you have a tendency to, you have an ability to just kind of stay in this place, right?
Right.
But it's not a place that you're enjoying, but, you know, you're not the wreathing, you know, crying, screaming stage, you know. And when you have a doctor who looks you in the face and says, I know you're in pain, I believe you, but I'm just not comfortable giving you the medicine. There's no pain scale that's going to change whatever it is in her brain that's stopping her from treating my pain. And it's a situation that, I don't know, makes you feel very helpless. And again, I know that, you know, if there was a white woman, 65 years old, laying in that bed, saying that she was in a pain level 8, come on. You know, the difference is just race. And it's a very sad fact of our American medical system and life that race taints everything. But again, I just appreciate whatever you can do, you know, to help this situation. And just thank you for being here.
Thank you so much. So in regard to the doctors, we had that a lot at Loma Linda about 4 or 5 years ago. Our providers, if you are confident in your knowledge and skills, you can talk to a doctor. But if you're not, you won't talk to a doctor. And so that did happen a lot. A lot of doctors said, I'm not comfortable, especially if they're not in a pain management specialty. But what the hospital did is they initiated an algorithm. So once a patient comes into the emergency room, they're automatically started on a PCA pump with fluids and different things that are specific to that patient. So I'm not sure how all the institutions function, but for the purpose of the doctor, if they can implement an algorithm, that makes it much easier, because once that's in place, doctors are okay putting in the order set, and it just automatically populates to the staff for what they need to do. And I think that at least getting the doctors out of the way with the algorithm and an order set, then now we just have to worry about the nurses. So we just have to look at the institutions and see what they have in place for sickle cell patients in that regard.
Thank you.
You're welcome.
Yes, microphone number 2.
Hi, thank you so much for being here and being
Thank
an
you.
ally and supporting this community the way you do. I was just, in the years of being a caregiver, I have tried to communicate with my son, not necessarily on that pain scale, but I don't know how effective it would be to add like a psychological factor like colors, shapes, sizes, weight, sharpness, dullness to the tools already used, because it's going to take a lot to make a change with what's already there. But then you have the factor of them not really feeling like even talking again. So,
Right.
I mean, there's so much associated with the pain that what the young man said right now it just blew my question out the park, because it's like nobody wants to even talk about it, because you already are faced with the problem of saying, well, I understand your pain, but then I don't feel comfortable giving you that medicine. Heard that time and time again. So I don't know, it's just a thought.
No, I understand. And the pain scale is a very great task to take on. So that's why, in my mind, I don't think, we're just now getting, and I learned this at going to the sickle cell boot camp in Tennessee, and that was an amazing experience for me, where I also met Ms. Pat. At that boot camp, it was so, in a sense, sad to hear how far research has come for sickle cell, and it's not far. So that's the thing, like, you think it should be where it is compared to cystic fibrosis and conditions of that nature, which is kind of relative, but that funding is greater, but it affects a smaller percent of the population. So I don't think a new pain scale is needed, because where are we going to get funding from? Like, we want funding where it belongs for the community, but you have to then put it to a new pain scale that may or may not even work, especially if the people using it are healthcare professionals who, in their mind, the biases didn't go away, the stereotypes they had about the patients didn't go away, the preconceived notions didn't go away. So if we're not really going to the core and just putting Band-Aids over the issue, then we're not going to get anywhere. So I really think going to the institutions and educating our nurses and healthcare providers will be the most beneficial for the community.
And after we take the next question from microphone 1, I have a virtual comment.
Hi, my name is Stephanie Starr. Thank you so much for all you're doing and will do. My question is this. I have been used to being in Southern California for my care. That's where I pretty much grew up. In that system, lead nurses always took over and made it a point to medicate if my nurse was off the floor, whatever. Coming to Northern California in a smaller area, that's not the thing. I've had to educate lead nurses in 2 separate systems up here. That's how it's done in other places. What would you suggest for that to be educated across and implemented across, like, nationally? That should be a national thing. That's part of the job of being a lead, is to take over for your nurses, not to turn around and tell me that, oh, she'll do it when she gets back from lunch. No, I need it now, not when she gets back from lunch. Back then, I'll have some other issue that I won't ask for, because you only see me when I ask for pain medicine. So how are we such a burden? Yeah, I get the time thing, but most of us aren't on the light like that.
Right.
So it's very frustrating when you know that you only talk to your nurses every 4 hours because that's when your meds are due. And you hear all this stuff about how much time it takes to take care of us, number one. And as to our little thing about everybody else being uncomfortable, what you guys are saying when you say you're uncomfortable with giving our medication is more than just not uncomfortable, you're not comfortable doing your job. You are comfortable watching suffering that you could prevent take place now. Thank you.
You're welcome. Thank you for the question. So I can't change the nurse, but every hospital has a patient relations department. Every hospital. And at any point you're not comfortable with the care receiving, ask to speak to the patient relations department. And that can make a big difference because it may not be an institution thing. It may just be that charge nurse. I can't speak to it, but I do know that every hospital has a patient relations department, and you can reach out to that department and they will take names and they'll ask the situation, and no unit wants patient relations involved in their unit. Anytime you get the call and it's patient relations, you're like, oh man, what happened? So you have a department called patient relations and you can reach out, tell them you want to speak to them, and you'll see differences. You'll see changes.
Thank you. And I'm going to say something from the virtual community. This parent has 3 sons with sickle cell beta thalassemia plus. One of the adult sons was in a severe pain crisis and was not tended to appropriately in the emergency department. When they were in the lobby, this parent went up several times to let them know that the son was writhing in pain. He could barely talk. And when he was taken back, they did not allow them to go with the adult child. So the parent was in distress, prayed and prayed and prayed, hoping that their child was being taken care of appropriately. Well, then later, the son told the parent that a nurse, a male Nigerian nurse who was not that patient's nurse, saw him in pain, stepped in, drew attention of the doctor, got stat orders, and gave him the medicines and the IV back to back as soon as possible, and then notified his original nurse. And this parent was ever so grateful. You know, Dr. Lin, when you started with your story, I thought you were telling us a fairy tale. I thought you were telling us like a made up story. And when I realized that it was you being that superhero nurse, just like this other individual, I was also grateful as an individual who lives with sickle cell disease. And I hope that we have more allies like these nurses that are shared. Now, our time is cut short. Let's take one more question from mic number 2, and then afterwards, maybe you can talk to Dr. Lin one-on-one.
Hi, I'll make this quick, and it's not exactly a question, but it kind of tells what Adrian from Axis had presented. And I thought the warriors may be able, even though one of the previous speakers talked about challenges in terms of color, shape, sizes. I think maybe in our support groups or other opportunities, we have to brainstorm in languages that may convey something other than the 1 through 10 scale. We could, through trial and error, may make some steps forward that could be significant.
Thank you for that. I thank you for your time, and I'm truly grateful and honored to be a part of this summit, and I hope to speak with you all soon.
That was impressive. That was so impressive. Thank you again, Dr. Lin. You basically emphasized this important point. Whose pain is respected, seen, and believed? We need to do a better job with sickle cell. And so our next set of speakers, we're really excited to have Dr. Osborne Blake and to share his journey as a medical provider and the journey to understanding pain management with sickle cell disease. Alongside in this panel is Dr. Wally Smith, distinguished professor, who is a trailblazer in the area of pain and sickle cell disease management and really understanding how do we manage sickle cell with compassion and with urgency. So with that, Gentlemen, take it away. And after your panel, we'll have time for some questions.
All right, good afternoon. Let me share my screen. Okay. Wait. Right. So my talk is going to be about sickle cell and the treatment of sickle cell pain. A lot of the issues that were brought up by the previous speaker, I may end up touching on some of them, and then we could also speak more about them in the Q&A. Okay. All right. So before we get started, let's put a definition on pain. It's an unpleasant sensory, emotional experience associated with actual or potential tissue damage, or described in such terms. Okay. And when you see this person, like the other speaker, or one of the questions was, my face looks the same whether I'm in 10 pain or 8 pain. But when you look at this person, you can actually see that they're actually in pain, right? But a lot of times we tell our sickle cell patients, use distraction, use whatever else you can to help with controlling your pain. And so a lot of times they get uh, the look as, hey, you're here for this much pain, but you're not in pain. The process of sickling is very complicated, and like you look at this slide and you see all of the different processes that are actually involved, where you get chronic vascular damage leading to damage to the tissue, especially in the small blood vessels, such as the ankles, leading to ulcers. You get inflammation and cell activation. You get multiple cellular adhesions. You get vasoocclusion. Then you actually get what looks like a mess in this blood vessel, where you get stickiness of all the cells clumping together. You have the adhesion factors and white blood cells. You have the stickiness on the vessel wall, leading to stagnation of the blood and therefore damage. When someone comes in with sickle cell, a lot of times you ask, what triggered your sickle cell? And you see in the prodromal phase, there's emotional stress, cold exposure, and a number of other issues leading to numbness, paresthesias, aches, and then a crescendo of their pain. And then in the phase where and most of the time patients say, oh, I started having pain 2 days ago, 3 days ago, and then you're seeing them in the emergency room in the hospital 3 days later, when they're already in the sickling episodes. Okay. Right. And then sickle cell pain also has with it neuropathic pain. Unlike uh, the regular pain that is caused by the vessel damage and other issues, most of the time the neuropathic pain doesn't resolve and actually progress and keeps going. We cannot talk about sickle cell pain without actually looking at the overall pain cycle. There's an estimate that about 50 to 60% of sickle cell patients have chronic pain. Okay. And when you're treating the pain in the hospital, you have to also take into account their chronic pain. And like was mentioned before, patients have one baseline they get severe damage, then they switch to a new baseline. But when they come in for that acute pain, we have to look at their baseline where they are. And then if you look, there's a lot of cycle that each sickle cell crisis go through. There's the ER cycle where they're being treated for the pain. Then they're hospitalized and they're on opiates. They get some pain relief. The opiates is then titrated down. They're discharged home. But when they get discharged home, depending on what they get discharged home with, they can go through withdrawals and withdrawal. That withdrawal can also lead to them being back in the hospital with another sickle cell episode. Okay. Like I mentioned before, because sickle cell is such a complex disease, the pain that they go through is also very complex. The pain is associated with lots of anxiety, maybe because there's some patients that's been told you may not live until you're 40 years old. So close to their 40th birthday, they start getting sickling episode, then emotions kick in. They actually start having more sickling episodes, more crises, because that's in the back of their head that now is a time that I might die. Okay. And then that's tied to other emotions of anger and just the unknown. And then the biological and the physiological aspects of the pain itself and the response. And lots of these are not psychiatric disorders, but they're just a response from the pain. Okay. And then the addition of the narcotics also, because not only does the sickle cell itself cause damage to the nerves and cause neuropathic pain, the opiates itself can cause neuropathic pain. And this is just a slide indicating the pathway for the neuropathic pain, going to the and the different pathway of inhibition and excitation of the nerve pain. Right. Let's look at sickle cell pain and how it's and the different aspects of it. So with vaso-occlusive pain, you get recurrent ischemic episodes with damage to tissue, leading to chronic inflammation, chronic scarring, and damage, leading to repetitive what's considered repetitive injury, and then they get chronic pain. Then you actually get with a sickling episode, you get the brain gets to this where it's always being dealt with chronic pain, so you get hyperanalgesia, right? So whereas it's like the last straw that broke the camel's back. So any little pain makes the whatever pain is there just so much worse. They can also have allodynia, which is just generalized pain, so that their skin is sensitive, their body is sensitive, so any kind of light touch or pressure can actually cause pain. You could get also opiate-induced hyperalgesia. So sometimes using too much opioids can also promote increased pain. And then the neuropathic pain, which can also add another layer onto these different pains. Okay. And then we mentioned the cyclic um, nature of being treated with opiates, then going through withdrawals, and then needing to be treated again. Right. So when we look at treating pain, one thing we do is we look at using some opiate titration. Opiate titration helps us, or rotation, sorry, helps us to mitigate the effect of tolerance to one opiate and the use of another opiate, and then it also helps because one opiate might bind to one receptor a little bit better, and then may not, and then that rotation can actually help to where the receptor, once it's off, the receptor gets a little bit down titrated and can help with some of the pain control. And then we look at some of the opiate tapers methods where you taper down the opiate a little bit slower, which can help to mitigate some of the cycle of the withdrawal. The use of buprenorphine and naloxone has been shown, and I'll show some studies later that has improved the use of this medicine for treatment of especially chronic pain in sickle cell. Non-steroidals, although with non-steroidal anti-inflammatory medications, you have to be careful because a lot of sickle cell patients already have renal issues, and you have to be very careful as not to exacerbate their renal problems. Right. And then you could use neuropathic pain medications such as Cymbalta, gabapentin, pregabalin to help with mitigating some of the neuropathic pain. The other part that we look at is optimizing the treatment of the disease, sort of like just looking at the disease-modifying medications, right? And hydroxyurea is the gold standard of that treatment. Glutamine and crizanlizumab. Voxelotor has been taken off the market, so no longer available. And then transfusions, whether sporadic transfusions or exchange transfusions can all help to reduce the sickling episodes and help with reducing the chronic damage that is associated with the sickle cell. And then looking at other comorbid conditions. I don't know how many times I've seen patients who, because of the nature of their A1C, A1C and their hemoglobin having hemolysis, having a lot of patients come in who has like pre-diabetes or early diabetes that goes undiagnosed just because we're using A1C. And when you look at the A1C for sickle cell patients, the A1C is actually comes out as 4.2. When you look at the fructosamine and use that as a to calculate an A1C, the A1C might be 7 with the calculated from the fructosamine. And so that's one intervention that we could use. And if you have both of those diseases together, you're causing more small blood vessel damage, more micro damage that can make the sickle cell worse. And so by us looking at other diseases, I remember a young lady that came in to see me. She started having worsening of her sickle cell, well controlled on hydroxyurea, but then all of a sudden started having more pain. Everyone just thought that it was sickle cell. But having the opportunity to sit down and discuss with her, finding out, it turns out that she was having rheumatoid arthritis. And when we treated her rheumatoid arthritis, she got better and is back to her baseline in terms of her sickle cell. Now, I haven't seen her never seen her in a hospital since the treatment of her rheumatoid arthritis. And so we have to make sure that not everything that presents with pain is sickle cell. And so we have to go through the history and find out exactly what's going on and then treat the other underlying conditions. Okay. All right. And there was a mention of treating well, we're going to talk more about acute pain right now. And there's a mention earlier about the importance of the pain management. And these are some of the key points of why it's so important to get adequate pain control, because it reduces the risk of adverse outcomes. One, you reduce the tissue damage, and you also just help the patient be get their mind a little bit better, right? Two, you maintain patients' functional ability, because if patients are in pain, they're not going to move. If they end up being immobile in bed, more than 2 days in bed, they can lose muscle, end up having orthostatic instability and problems, right? And then poor pain control reduces the quality of life. And if you have good pain control, you get shortened hospital stay and reduced costs of healthcare. Some of the problems with over controlling pain is respiratory depression, circulatory depression, sedation, nausea, vomiting, pruritus, um, uh, or itching, and urinary retention, and constipation or impaired bowel function. Okay. Poor control of pain can also lead to pulmonary embolism, um, endless suffering, and worsening of chronic pain, and damage to and causing more pain, which means because of more tissue damage, right? And so a lot of times when as a provider treating pain, you may feel like you're pushing a big boulder up a hill, um, right? But if you just look at making sure that you partner with the patient, I think that will actually help. And so we just have our goal. Oh boy.
And thank you, Dr. Blake. If you can, are you almost close to the end? And then we'll have time for questions as well.
Oh, I don't know why this so if we just have our goal as making sure that our patients get good pain control, making sure that they have around the clock control, that is actually helpful, right? And then if you look at this person right there with all the rings, you might think that that's painful, but like someone mentioned, sometimes someone's 10 pain is someone's 6 pain. And so we usually use the pain scales and go with what someone is comfortable with in terms of their pain. And as was mentioned, the pain scales have been validated in all different types of pain. The issue is that it's not been used appropriately, right? Some of our routes of treatment of pain for pain medication are PO or oral, parenteral, so such as IV, per rectum, IM, transdermal. Okay. We typically use opiates for pain control, and the opiates bind to the mu receptors. I don't know why my slides are going in and out. So they bind to mu receptors, and the receptors are how the pain is controlled. So one of the thing is when we actually convert patients after having adequate pain control. So someone says that their pain is their tolerable pain level is 6, or the most common is 4. So once their pain is controlled, then we typically actually try to convert them to an oral dose that is equivalent to what they're on, and then have them go home on pain medication, get their acute damage controlled and healed, and then start their weaning process back off. Okay. Um, and then just using small doses of analgesic drugs administered um, during in a pain patient in a PCA, we have not been noted that that has been helpful. A lot of our patients told us that when they get the standard PCA, they typically don't get good pain relief. They feel sleepy because they're having a constant dose of medication. But what happens is they they don't get the pain relief when they press the button. So what we did working with our patients, we actually change it to where they get no basal dose, right? They get a demand dose that's higher when they need it, and then we actually end up giving them like a longer time between dosage. So instead of it being a lockout of every 10 minutes, we have a lockout of an hour or 2 hours based on their pain. And so we may give them two milligrams of dilaudid every 2 hours, which helps their pain. They don't have to wait for the nurse to come in and administer their pain medication. And because they don't have to wait for the nurse to come in and administer their pain medication, they don't have to deal with a nurse having to go find the key, find another nurse to observe the procurement of the medication or or getting the other issues. It's almost time.
Yes, sir. I can you hear me okay? I think he can't hear me. Yes, Dr. Blake, it's time, and we want to save time for questions as well. So if you're okay, if we
All right.
move to the
So
next speaker.
yeah, so we'll go.
Yeah.
So like I said, we've like a lot of times what we've noticed is that with buprenorphine has been shown to actually help a lot with chronic pain in sickle cell patients, and using buprenorphine has helped us to actually get patients uh, good pain control, reduce the some of the cycling of opiate withdrawals, and it has helped to enhance the benefit of the disease-modifying medications such as the hydroxyurea and the other medications. They still end up sometimes coming in for chronic for your acute pain, which may not be fully covered with the buprenorphine, and so we temporarily have to stop the buprenorphine and use dilaudid or morphine for pain control. But then once it's after their pain is controlled, then we can switch back. All right. These are just a slide of some of the other control of pain. This is Toradol, which we also administer. And like I said, have to be careful, depend on patients' comorbid conditions. We use lighter derm as well for some relief. And then just a thing about CBD. CBD has been shown to help with some pain because of the receptors that are in our bodies, right? And so it can help, but also it helps with some anxiety, which can also help to reduce the pain. Right. So because sickle cell patients have been well cared for.
Yes, so sorry. I think there's an audio problem, sir. Yeah, thank you so much. And I apologize to cut this short because we are learning so much, but we also want to give time for questions. Okay. Can you redo your audio? We're gonna go to the next speaker, Dr. Smith, and so if we can spotlight him and he can get his presentation ready, and then we'll work on Dr. Blake's audio visual. So sorry, we'll work on Dr. Blake's audio so that he.
No, I'm fine.
All right. Go ahead, Dr. Smith. Thank you so much for joining us. And thank you, Dr. Blake. We're excited to learn more from you.
Why don't we go straight to questions?
We actually have a little bit of time if you want to give for your talk. I think maybe if you can do it in 5 to 10 minutes.
Does anyone have any questions? We don't have anyone lined up at the mics. So if you have a question, please line up at the mic. But someone is approaching, so stand by.
Okay, and Dr. Blake, can you hear us now? Okay, good.
Go ahead.
Thank you.
We can go straight to questions too, Dr. Titi.
Okay.
Thank you once again. My name is Shira Arrington. I'm a sickle cell warrior with beta thalassemia, and I am one of Dr. Osborne Blake's favorite patients. Dr. Blake, I wanted to say that you said something quite important and pivotal to my life, because I remember I was traveling over to Africa, and he said I should get infusions, meaning I should get a bag of fluid for the hydration. Well, that made my trip not only memorable, but pleasant. Also, you mentioned about being tested for my A1C. I was in the process of prepping for surgery for tendonitis in my right hand. The doctor took a blood test, and my A1C was 6.7, which means they cleared me for surgery. Because of my rapport and the education with Dr. Blake, I know he was talking about pain, but this is vitally important because it actually saved my life. With my A1C being 6.7, they approved me for the surgery. So when I was in consultation and my healthcare advocate was there with me, they said, well, wait a minute, what about her phoresis? Because her primary doctor for sickle cell always tests to check her glucose in her blood. So they did the phoresis, and unfortunately, it was high. So I was not approved for surgery. And I appreciate Dr. Blake for his tenacity, for his relationship with all of his patients, with me being the favorite. I just want to thank you so much for all that you do for sickle cell warriors. So that's my comment, and thank you so much.
You're welcome.
That's so wonderful. And I see that there's another person at the microphone, so maybe we can take that question and we can see if our panelists can dialogue a bit. Go ahead.
Sorry, I'm short. Okay. I'll just take it out. Yeah. All right, can you hear me? Okay. So, hi everyone, my name is Brianna Capers. Just a quick question. You mentioned about the PCA. One comment that stood out to me was about the way that you have a tendency of setting the PCA properly. And I think sometimes, at least in my experience, for some reason there seems to be an issue or like a hesitancy when it comes to navigating the settings of the PCA. So you mentioned, for example, if the patient's on 2 milligrams every 2 or 3 hours, then that's what you should set it at, not 0.3 every 10 minutes. So is there a specific reasoning or guideline behind why there's this issue of when it comes to writing the orders for the PCA? And what are some ways that as patients we can go about requesting the settings to be properly set so that more warriors can actually get a benefit from the PCA? Because that seems to be the biggest reason why most patients don't want to use it, is if you're going to give me 0.3 every 10 minutes, no thanks.
Yeah, so what happens is it's not that it's like the standard PCA is actually for cancer patients and post-op patients. Okay, and those patients have like a constant level of pain that is always there, and a small breakthrough pain. And so with a constant level of a small dose of medication that's in every hour, and then a tiny bit when you press the button, when you have a tiny pain spike, when that helps those type of pain. But just having discussed with our patients, when we use PCA, they said they don't get any relief from the pain medication, and having a conversation and finding out why, we find out that they have um, almost minimal to no pain control with the basal dose. And they feel sleepy and tired because of the basal dose. So the basal dose is always going and in the background. And then when they press the button, during the pain spike, it doesn't help. And so it's just more of communication. And so we decided that we would change the PCA to what they wanted. The PCA, most of the time, they would like to get 1 milligram that helps control their pain, or 2 milligrams, whatever they have noted to get pain control with. And so we switch it to that, where the PCA will administer that whenever they push the button. And because it's a PCA with the medication already in it, whenever they feel the pain, they could push the button, they get that dose, and then they don't have to wait for the nurse to come in and administer the medications. And so we actually find it that they get better pain control longer and pretty quicker. The other hospitals may not do that because, like I said, a lot of it has to do with just having conversations and communication with our members and finding out what works and what doesn't work. And it took a little bit of advocacy to actually get this PCA put in. And so we actually have a library in our PCA system that says sickle cell library, and this is what they put in.
Thank you, Dr. Blake. Dr. Smith, did you want to add to that question from your institution?
We studied PCA patterns in children and adults. We found basal PCA work better in children. They're younger, less opioid tolerant. But in adults, the self-administered demand doses worked better. And all adult providers are afraid of the basal doses because it could kill somebody overnight, left alone. People open the door and the patient's not breathing. So we, hospital by hospital, people make up a policy, but our policy is no basal and in adults, and demand dose PCA for pain in adults. Titration is the word that I would like to emphasize. Dr. Osborne hinted at that in the discussion phase that he was talking about. So we start out with a dose. We say, did that work? And if it didn't work, we might go 1.5 to 2 times higher and find out if that worked. So we titrate to the dose that works in order to get adequate pain control. Pain in a sickle cell disease during an acute painful crisis is almost an on-off phenomenon. Certain amount of opioid will give you almost no pain relief. And a small increase in the dose sometimes will make the difference. When the patient goes, I feel it. So titration is very important and often not done. It has to be done rapidly during the first 24 hours of the hospitalization. And it has to be done frequently enough so that by the time you get to the 72nd hour, you're ready to go down. We have something called TOTP, which is a kind of goes with the phases of the crisis that Dr. Osborne showed. And we let the opioids go up, titrate up rapidly. We have a plateau phase, and then we have a decrescendo phase.
Thank you. Thank you both. And I saw that there was somebody at microphone number 2.
Yes. Hi, I'm Tondua Washington. I am an SS warrior and a pediatrician, and I take every opportunity to shout out Dr. Smith, who was my doctor while I was at VCU for medical school. I really don't think I would have made it through medical school if it wasn't for your assistance and expertise. So thank you. And Dr. Osborne Blake, I haven't had an opportunity to meet you yet, but I thank you both for presenting today. My question is, as I've gotten older, I've had to deal more with chronic pain and neuropathic pain, and I do not enjoy taking opioids. I really use them as a last resort. But what I found in my own journey was medical THC has been really helpful. So I have, capsules, tincture, which I use very rarely, but the main thing that helps me is a THC cream, topical cream. And I just was wondering what your experience has been with using THC as an alternative, especially to opioids, in the management of chronic or neuropathic pain, if you're doing that more, what your experience has been, and what research maybe is telling us about that.
Thank you for the question. Why don't we start with Dr. Smith?
The research is slim because of legal issues in trying to conduct the research. The subjective and anecdotal experience is that it all helps. We do not condone smoking, and people who smoke marijuana, we try to get them converted over to edibles or topicals or others. In the state of Virginia, any person wanting THC can get it at a dispensary from anybody who's a doctor who has signed up to be able to dispense it. And so we freely dispense it. We have not conducted studies of how well it's going. We have people saying they, swear by it and say it does help. A lot of the responses are it takes the edge off. And I think what that means is an anxiety, an emotional component to their pain that is dealt with. But there are receptors from the CNS all the way down to the periphery. There are cannabinoid receptors. And in mice, there is a lot of endocannabinoid and other cannabinoid researchers working on this. So stay tuned.
Thank you. And I also want to say one of the things it does for me is help with sleep, which indirectly helps with pain. So I always,
Sure.
yeah, so.
Yeah, it's a bidirectional relationship that cannot be untangled. Which one causes which? Poor sleep causes pain, pain causes poor sleep. Just keeps going around. It's a vicious cycle.
I wanted to just double check. Dr. Blake, did you have anything else to add about the THC question?
Yeah, no, I agree with Dr. Smith. There's only small studies that look at patients who already have like a marijuana card. There's one small study that looked at about 52 patients, and it showed that there was a significant reduction in the use of opiates for pain control. And so it can help. And I agree with Dr. Smith's, a lot of the new studies out right now that talks about the opiate, the marijuana use and damage to the lungs, as well as increased risk of CAD is associated with the smoking of marijuana, and so yeah, we wouldn't recommend smoking, but topicals and edibles are fine to help reduce some of the pain.
And can you, just for context, can you tell us the acronym CAD you said?
Oh, sorry, coronary artery disease.
Oh, coronary artery. Okay, just making sure. Thank you. That's helpful.
Thank you.
Sure.
And thank you for that question. I believe I see somebody at microphone number 1.
You do. So Dr. Blake, it's Pat Corley.
Hi, Pat.
How are you? I just want to say that I am so proud to have known and had the experience of seeing you as you were a doctor at Los Angeles County USC, and to go on to do major things for the sickle cell population, the things that you're doing and standing in the gaps of care for people living with sickle cell disease, and that you've made a difference. But I want to ask you and
Thank you.
Dr. Smith, how do we get other people to come into that to that arena so that we can ensure that we have the services that we need for people with sickle cell disease? Because it's really hard to get people to buy into taking care of people with sickle cell disease. They have a lot of judgment.
Yeah, so I think a lot of it is education and just kind of like trying to show that the importance of taking care of sickle cell patients. We have a little bit of benefit because we have a closed system at Kaiser, and the closed system allows us to be able to, interact a little bit more with our hospitalists, our emergency room physician, and we also are able to, like put things inside the chart that can help our members when they go to the emergency room. But we're actually trying to get our hospitalists to take a little bit more ownership of our sickle cell members, and like it's a little fight, but we're getting there. But yeah, it's always just like pushing and trying to get people to understand and be aware that it's not a disease that they're not no different than our other patients. It's just the comfort level of dealing with pain for a lot of doctors becomes more difficult. And then with education and some hand holding, they can actually get get where they need to go.
Dr. Smith?
For any caregivers interested in learning more about pain and sickle cell disease, we published a book called Managing Pain and Sickle Cell Disease, Oxford University Press, and providers and caregivers alike may be interested in it. It's case-based, and so it may be attractive, Pat, to have people read about themselves, say, oh, that's me, that's my case, and see what we recommended, or to have providers who are having, every provider that has a sizable sickle cell population is going to have a few patients that cause them grief and give them headaches, and they never want to see them. And then they have the favorite ones, like the ones that was at microphone here recently, and then all between. And we try to cover each one of those cases in our book about people who've had a hard life and are not trusting of the medical system, and the doctors and them are having fights, as well as people who are, say, in their childhood years and are trying to figure out how to make it into a healthy adulthood. We try to cover it all, inpatient and outpatient.
You. I am so sorry. We could go on forever, but we really want to respect the time and also to make sure that you don't miss any other parts of the conference. And so we will end with that final word. Dr. Blake, Dr. Smith, thank you for being champions for sickle cell disease pain management. Thank you for teaching us to follow the evidence-based studies that exist for sickle cell. Though few, they do tell us how to treat people with sickle cell disease properly for their pain. And then it sounds as if you're advocating that our hospitals and our centers develop the expertise, either by getting experts to teach them, developing protocols and algorithms, making sure that we understand what works well for adults with sickle cell disease as well as children with sickle cell disease. And thank you also for compassionately answering the questions that were brought forth. I can see why your patients are self-declaring because they love you. And I wish we could clone you for more patients. But thank you so much for sharing your wealth of knowledge with us. And we're looking forward to the next part of our session. Thank you both.
You're welcome. Thank you.
All right, and I think I see Ms. Adrian getting set up. You know, we've talked to an ally advocate, we've talked to physician advocates, and now we want to hear what the community has to say, what the community wants medical professionals to know about their pain. What I loved about the Q&A sections for each of our discussions, you heard individuals with sickle cell disease already express their stories in beautiful ways.